Welcome to the Washington Opioid Data to Action Peer-to-Peer webinar series. Today we are talking with three exceptional individuals in the correctional facility community in Washington State around MOUD and correctional facilities. And this work is made possible through our opioid data to use funds through the Washington State Department of Health. And next slide, we are going to have some fun. We want you to click on the view options and choose annotate, and then choose a stamp for yourself and let us know where you're located so that we can welcome you. It's wonderful to have voices and representation of harm reduction champions around the United States. Georgia, Ohio, Utah, Nebraska. I love it. And if you want to come off mute or put in chat where you're located, who you are, and where you work, that would be great too. Enter your name and your organization in chat as well. And you'll be meeting each other in the breakout groups here in a bit. All right. I know Regina's over in New York. Anybody else over on that side? Whoa, Florida, Delaware. Wonderful. Okay, looking good. Whoa, very exciting. Michigan. Great to have all of you. All right, next slide. Yeah, this is our monthly peer-to-peer learning series every fourth Tuesday from 10 to 11 Pacific Standard Time. We have a robust 25 to 30-minute discussion, and then the highlight is going into breakout groups and meeting peers from around the United States. And we would invite you, because you're registered, you automatically will get information about our series through August. April is public health messaging in the fentanyl crisis, what works, and our panelists will be Laura Gover from the Rescue Agency. She helped to build the Laced and Lethal campaign in King County. We're really privileged to have Laura join us in April, and we'll be doing a World Cafe model for our session on that day. In May, MOUD in rural communities. Next slide. This is the schedule for this morning: intro, panel discussion, breakout, and then a lightning round report out. We also do a poll at the end of the hour, and we do rely on your feedback to let us know what we need to improve and how effective we are so that we can be better next month. Next slide. This is the team that makes it happen. You will meet some of these folks in your breakout group, and we're grateful for all of the work from month to month to find our panelists and get our materials in order so that we can bring an effective and timely topic to you. And with that, I'm going to hand it over to Dr. Michael Parchman.
Thanks, Maria, and good morning, everybody, or good afternoon, wherever you live. So thank you for joining us. I just want to remind everybody that our goal for these peer-to-peer learning collaboratives is that we learn from each other. And our hope is that you come away from these sessions having learned something new that is applicable to your work in your setting, wherever you are, some new understanding, some new insight. Now, having said that, I think what we're talking about today, there is I think we're in the middle or somewhere in the spectrum of a paradigm shift in terms of how we think about SUD in correctional facilities and the role that correctional facilities and the people who work in correctional facilities have to play in helping us think about substance use disorder from a community perspective, from a statewide perspective, from a public health perspective. So we have, I think, some really excellent panelists who join us today who work in correctional facilities. to have a discussion about this topic. So let me introduce them to you. Sherry Reeves is an SUD navigator for the city of Hoquiam in the Hoquiam City Jail, which is here in the state of Washington. Erica Turley is the jail substance use disorder program manager for jail health services for Public Health Seattle King County, again, here in Washington. And Lieutenant Jeffrey Gepner is at the South County Correctional Entity, which is again here in King County, which is in the state of Washington. So we're going to present to you, I think, a Pacific Northwest perspective on sort of what's going on in three different, subtly different kind of correctional facility settings here in the state, and have a conversation with them about their work and what they do, and what they're thinking about. So Sherry, I'm going to start with you, if you don't mind. Can you tell us a little bit more about yourself and your setting in Hoquiam where you work?
Sure. Yes, I started in this position about 6 months ago. It was October 1st. The program was not up and running yet. It was still kind of an idea. We had parameters, minimal parameters on what we wanted to do with the program. And we're serving at the moment 2 of the city jails, the 2 city jails that serve people with misdemeanor offenses. And there was already a program starting up in our county jails. So we modeled a little bit after what they do. But the folks that we have are not incarcerated as long as they are up at county. So it's kind of more of a rapid fire response than it would be in a county setting, because we don't have a whole lot of time to do it. There's no therapy involved, anything like that. It's MOUD and reentry planning is what we do.
Sure. So why do you think it is important to do this work, given those circumstances?
Withdrawing in jail is hard on everybody, staff and the people that are withdrawing, and as well as the other incarcerated individuals. It doesn't do anybody any good to have somebody that's suffering like that in the jail. It causes anxiety, it causes depression, it causes a lot of things that that there's negative outcomes for everybody involved. Being able to help somebody with medication to help them through that just brings a little bit more hope to somebody that maybe they can do this on the outs. We've had people that have never had any kind of medication for their substance use before they came to jail. We've had people that have detoxed multiple times in jail and maybe decided that now is the last time, now that they've gotten clear while they're in jail and they're not just raging against the system and feeling like, miserable the whole time, that maybe they can start thinking ahead towards, all right, I don't want to do this again. What am I going to do when I get out?
Yeah. So that brings up the subject of transition care planning, right? I mean, what are they going to do when they get out? And I understand from your perspective, being in the correctional facility, that can be a challenge. I mean, how do you do transition care planning for people? So what are you doing? What's the biggest challenge you face with transition care planning, and what are you how do you plan to address these challenges with this transition care plan? I know that they're only a short time, right? So what does that mean for you?
Well, I developed I've been developing helpful forms and things like that. And I've got a plan now where when somebody comes in, I have like a checklist of the things that I want to do at the first time. The first time I meet with somebody, I usually do a COWS to get their withdrawal score, where they are currently. Because we've had people in all phases, people that are not yet detoxing, people that are already in the throes of detox, just to get an understanding of where they are. I'll do a UA and then I contact our provider, because I don't do anything with medication. I'm a navigator. And then once they've had meds on board for about 24 hours, I'll go back in and reassess their COWS, start talking about where they might have received treatment prior to coming in at any stage, where they might want to go when they get out, maybe their dosages and how they felt that was working for them, get their perspective on their medical choice, what they want to do. I'm starting to contact their MCOs so that we can do some planning. Once I get a release of information, I might have to wait till the second visit to do that with somebody. They might not be feeling well enough at first to talk about any of this, but the soonest that I can get in front of them and start talking about resources and bringing in community partners. We have some agencies that'll help with housing, with recovery services, things like that. I can bring people that I know from out there, from in the community, or that they may have engaged with prior. If they're at the homeless encampment, maybe they've had some interaction with one of our team members that does street outreach. And we can bring them into the jail as well and have a conversation so that there is that connection when they get out. And they're not just let out with a list of things to do. They've got to accomplish all this stuff by the next court date. This is more of a warm handoff. No matter where they're going to go, if they're going to get into housing or if they're going back to Tent City, whatever their next step is going to be, that there's somebody there to greet them.
Yeah. So can I just ask you about the scope of this problem? Is this like one new person a month, one new person a week, one new person a day?
Well, we got 3 yesterday, but since we started, we've served 34 people in the Hoquiam jail and 15 people in the Aberdeen jail. Not all of them with medications, because we did not start providing medicated assisted treatment until December 22nd, I believe it was. So we've only been able to help with the medications.
So this is just like in the last 3 months.
Yeah.
Those numbers, right?
Yes.
Yeah.
Yep.
Okay. Yeah. So not a small rare occurrence.
No. And sometimes we get people in that their first time they come in, they're distrusting. They don't want to talk to an officer and admit that they used prior to coming in, as if that, they
Yeah.
Sometimes there's the stigma, there's the, fear of getting charged with something else. So we have to have that conversation too when we do the urinalysis, that is only for making sure that the medication is proper when we put somebody on medication and not for any more charges. But yeah, then they'll come in the second time and be like, well, I guess you guys help with this stuff. And, I got asked for yesterday by 3 people that came in. They wanted to see the SUD navigator because they don't want to get sick while they're here. So
what do clients tell you about their experience since you've been doing this work in the last 3 months? What do they say?
Overwhelmingly, I hear gratitude that they don't have to be sick while they're in jail. I ran into a person that we helped early on. She was not given medication because we didn't have it at that time, but I met with her frequently, and she's got a job as a waitress, doing really well, has been housed now for about 4 months, and is just doing really well. It was the wake-up call that she needed, along with the encouragement that she needed at the same time. So that was really, really, really great to see. We've had a couple of people so far. We can't claim success stories at 6 months in, but that are on their way, that are doing well so far.
Wow. That's so great. Amazing stories. I love stories. That's great. Erica, I'm going to turn to you next. So tell us a little bit more about you and the setting where you work and your role in that setting. What do you do?
Get off mute. So like in the intro, I'm the substance use disorder program manager for jail health services. So we run the clinics in the King County jails. I've been here for almost 4 years, just about 4 years. And so King County Jail is we're a pretty big facility. We have 2 different jails. We have one in Kent and one in Seattle. The average population between the 2 is about 14, almost 1,500 people a day. And our Butte population runs about 10% of that every day. My job as substance use program manager is to look at, to manage the Butte program or inductions, continuations and stuff. It is also just to kind of look at substance use disorder services overall in the jail. it's really about integrating kind of our practices within medical and psych and release planning and all of those various places.
Wow, wow. So let me just review those numbers again, make sure I understood. About 10% of the total population on any one day is enrolled in your MOUD program?
Right, who are on Suboxone. So about 150, on average, 150 people per day are taking Suboxone. It's about
Amazing.
75% of them here in Seattle and about the other 25 approximately
Wow.
in the Kent facility.
Wow. So you used to have, I think, if I remember correctly, you used to have a cap on the number of people who could undergo a buprenorphine induction at any one time, but there isn't a cap anymore. How did that happen? What changed?
Yeah, that was when we first started. So our program launched in March of 2020, and that kind of coincided with some other big events going on.
No kidding.
COVID. And it kind of delayed. We had a grant that allowed the grant was for inductions, but also for SUD staff. So we have SUD professionals on board. The reason we started small is because we did a pilot at first, and that pilot was like, we can only do 5 people because we couldn't move around the jail. We've never done continuation. We didn't know how many people to expect. So we started with 5, then we went up to 20 and then to 25. That was all only here at the Seattle jail. Then we took that to the Kent jail and we did the same exact thing, started really small. So from June to December of 2020, that's where the caps were. Come January 2021, we removed all the caps. And so we kind of grew steadily from that time in January 2021 through the fall. So about October-ish, we got up to the 10% number, and we've been holding steady since that point. So a little bit more than a year at 10% of the population.
Yeah, that's amazing. That's amazing. So how big is the staff that run this program? You and
So I think I might be the only one who classifies it this way, but we have our medical providers. So they are the ones who do the medical side of things. They do the dosing and they do the follow-up appointments. And then we have our SUD team who does a lot of the care transition, the care planning. So we have our staff of nurses who do prep the meds in combination with our pharmacy. And there's, I think, 5 nurses a day here at Seattle that do all the med administration and our pharmacy staff. So we have some dedicated pharmacists who just do bute. When people are inducted, they're seen by a medical provider. Like as soon as we put in the order, that a medical provider comes in and make sure that they're not having side effects. But the SUD team, right now we have 4 SUD professionals who are assigned to anybody who's on Suboxone. And we have 1 person down in Kent and 3, soon to be 4 people here up in Seattle. And their job is to do a needs assessment, to do a brief intervention. So we're doing an SBIRT model where it's screening, brief intervention, and referral to treatment. And so our team of 4 or 5 people do that part of it.
yeah, right. So you mentioned this just briefly a minute ago, but you were telling us before a little bit about your coordinating discharge program, right?
Mhm.
What is that and how is it helpful?
It's the first time here in King County that Jail Health Services and the jail DHAD, so it's the Department of Adult Detention. So it's the first time in our history that we're actually coordinating at release. Historically, Jail Health has been the only one who's doing the release planning and the care, the transition planning for people leaving jail. We would never know when someone's being released. We didn't have a way of communicating that. It was really just luck in a lot of ways, because we could follow a person's case, talk to their attorney, get a date, and it was never a sure thing. Someone could be scheduled to be released today, but then things change and they're not getting released, or someone's supposed to be released next week, but they get released today. And so any amount of that care planning kind of fell apart because of that, those variables. So about a year now, is it a year? I think it's a year, June of 2021, we started our coordinated discharge process. And that means that the jail is emailing us when somebody who's on Suboxone is about to release. And they give us 90 minutes to get a 7-day carry. So we request from our pharmacy, we get 7-day supply of medication. We schedule a same-day appointment with a MOUD provider in the community. We arrange transportation, and then we get all of the other various resources for that person.
In 90 minutes?
Yeah, well, sometimes it's even less than 90 minutes because, you know, there's somebody standing at the door saying, tapping their toe, going, come on, we're about to release. But the plan is to have 90 minutes. And we're working on a way to have the jail system, their case management system, talk to our medical record system. So it's not a person emailing us, but rather as soon as the jail enters something into their system, it'll send us a notification. So we're thinking that might give us a little bit more time since it won't be so person dependent.
Yeah, so the typical large organization with silos where nobody talks to each other in their respective silo, right?
Kind of, yeah. I mean, it's difficult. Just there's so many different silos.
Yeah, and
So
a lot
for
of
the-
moving parts.
a
Yeah,
lot of moving parts.
yeah. So what's next? What do you hope to do next?
Well, we're expanding our coordinated discharge outside of people who are in Suboxone. So soon it will be more folks. So like if you're on a psych med, so we can request psych meds at release. Right now we need 3 days in advance notice. We're hoping to add that to Suboxone. We're expanding it to folks who are HIV positive, Hep C positive, or meet another, this kind of, we have some set criteria. So if you fall within those criteria, you will also, we're calling it a health hold. So we put a health hold on their release packet, whatever. And so that will notify the officer to notify us when they're releasing. So we're expanding that. We're also, as part of that, this spring, we're going to be convening our stakeholders. So like of our community partners, our FQHCs, the folks who receive our people when they leave jail, as well as our community mental health centers, just to kind of best strategize how we can do that one handoff. With the jails reopening, hopefully it could have more in reach. And so we can catch people before they're at the time of release, and with some, with some more input from our stakeholders, we can hopefully increase that. I think our biggest weakness is that time after release, a person, they leave jail and then poof, you don't know what goes on.
I can't imagine being in their shoes saying, please don't release me. Please don't release me. I don't want to go through withdrawal because I don't have enough buprenorphine to last me until I can get into the primary care clinic, right?
Well, yeah, I mean, we get people, about 80% of our folks are new inductions, and
Right.
so 20% are already coming in on view, but those 80%, which is most of the folks, are really just like wanting,
And then you're
view.
scrambling, trying to find somebody who will see them within a week, right?
Yes, and we have our go-to people. What we're doing, hoping is that we'll increase that, so we have more places to send folks.
Yeah, right. Amazing, amazing. So Lieutenant Jeff, you're at the SCORE correctional entity. So how is SCORE, where you work, different than where Erica works? Tell us a little bit about SCORE and the facility and the place where you work.
Well, SCORE is actually South Correctional Entity. We are a multi-jurisdictional regional misdemeanor jail. So we're owned actually by 6 small cities that are surrounding Seattle. What we found is that we're pretty good at what we do, and now we book most of Western Washington. So from the Canadian border to the Oregon border, we're kind of known for we call them our 3 M's: MOUD, mental health, and medical. So our smaller jails that only have maybe 30 to 60 beds, they'll send us their patients so we can provide those services. What's nice about it is that it's a way that we are able to bring in a lot of the community members to really give them a chance to interact with the patients that we have here. And I think that's a really big key to success, because we're only going to have them for a short amount of time. So we always prefer a longer amount of time to be able to provide additional services, get them stabilized a little bit better. However, we aren't the ones who choose who come here, but we're going to do the best we can. And the best approach we found is, who are they going to be working with in the community? They are the experts. They are the ones who we really want to rely on, because that's where we hope they spend most of their time, is with that part of that community. So they have that familiarity with people.
Right.
And especially coming out of a correctional facility, a lot of people, there's a huge stigma around it. A lot of folks unfortunately still look at them as criminals, or they did something wrong, not realizing that it's substance use and mental health, and I think a big way of just looking at the person in a little bit of a different way is really important, and I think that's what we have an advantage to, is with our officers here and staff, and, the willingness of people to actually come in and, provide their services here.
So you've talked about this before. I've heard you say, think of this as a timeout opportunity. Can you say more about your thinking about a timeout opportunity and why and how you think about that?
Yeah, there's a lot of opinions, around that. But from what I've heard from the folks we've had here, is just like, I can't control myself when I'm out there. I don't have the resources I need. I don't have the support I need. So sometimes somebody kind of helping me out and kind of guiding me down a path where they still get to make their own choices. They get to choose. It's not up to me what they do or how they do it, but we want to provide them those opportunities to be able to choose, the direction they want to go, but giving them that moment of kind of, way to find some clarity to, kind of change their perspective a little bit. And I think that's what I've heard a lot of the folks that are in recovery have said I kind of needed that time for myself to kind of work on myself. So. Yeah.
I've also heard that you're a teaching facility for Washington State. What does that mean, and what do you do as a teaching facility?
So we're kind of pretty unique. We've had numerous other facilities throughout, part of the country. We're actually a COSAP mentor site. We've helped numerous jails throughout Washington State, Oregon, and Idaho help set up their programs of just kind of, how does it work? What does it look like? Because as a correctional facility, we used to have one job, and that's taking care of people of their custody. Well, now we're working with mental health, substance use, social determinants of health. So trying to really understand that, you're asking a system to do new things. And so we're able to start plugging in with University of Washington, Washington State University, even other ones across the nation for internships. So we have MAs, LPNs, NPs, whether it's psych or whether it's physical or mental health or MOUD. So,
Do people come to you for an internship?
Yep. So, and this is through our contracted medical provider or even custody staff. I've had a handful of interns where, they're trying to understand, the legal system and how it works and how it's set up and how it can function better, or how to even navigate it. So it's nice being able to provide that, because you exponentially increase the capacity you're able to serve, our population, which I think is definitely underserved.
Right. Yeah. Teaching other people how to fish. Yeah. I love it. What about care transitions? Eric and I were just talking about that, and Sherry and I were talking a little bit about, that people are with you only a short period of time. What about that care transition process? How do you ensure follow-up? What are you doing? What are you working on? How does that work?
Yeah, that's always been our struggle of we have so many people coming in here, approximately 10% of our folks are getting, case management services to some extent. But I think a lot of it is, once they leave our front door, where do they go? How do they get there? There's so many different barriers involved. It's great we can get them on an MOUD program, but that's where I think, facilities like ours need to make sure and understand that there's a lot of social determinants of health that are going to, kind of dictate the outcomes. So what we've kind of decided as an agency is to bring the community in. they're the experts in this field. So you're meeting them where they're at. And I think that's where, a lot of us struggle, especially in our line of work, of like, it's very unusual for somebody coming in to provide some of those services, but we find that it is having that direct connection with somebody you're going to see on the outside.
Yeah.
And you build that relationship, especially with those case managers, is they have somebody to trust. They have, they're not going to be judged when they leave. They already know something about them. And I think that's what's really effective, as far as the community goes.
But you've got the issue of, you've got smaller communities all over Western Washington who send you their clients. So it's not just the community where geographically you are operating, it's all these communities that you have to work with, right?
It's really throughout the state. We've really turned ourselves into more or less a hub. So we have connections all across the state. We try to find larger providers, make connections. I mean, join groups like this, where you actually have that face-to-face relationship of going, hey, I know somebody in, Spokane that I can talk to or have that connection. And I think that's what's really important, especially is for a jail, of being able to really network and understand that approach of going, not only do you have an MOUD problem, you also have a primary care, you also have some mental health, you have housing, you have, and that's what's people really need to take a look at, is really get down to some of those even root causes of,
Erica, you're nodding your head. What do you think?
Yeah, I mean, I agree. There's all those social determinants of health are key in linking people. I mean, we're not gonna solve all their issues at release, right? We're gonna hook them up with folks that hopefully long term they can if with some solid connections with housing, with a housing case manager or something like that.
Yeah.
And the housing case manager with a good linkage, then they're on the right road.
Wow. Sounds like you're kind of like an air traffic control tower almost, trying to land the planes and help them take off without crashing into each other. That's awesome. That's awesome. Sherry, what do you think about this? What's being said about this process and challenges in your community? How does that work?
A lot the same, even though we're on a much smaller scale. We find that bringing people in to talk to folks before they get out, so they have that touchstone, is really helpful. It's really beneficial. We hear that a lot. People that were coming in before we started this work, I've been at this intersection of behavioral health and criminal justice for about 5.5 years, and I heard it over and over, where people would, they'd hear good things while they were in jail, and then they knew as soon as they got out, they're on their own.
Yeah.
And they'd come back and just be like, I just, lost it when I got out. I didn't know what to do or where to go first. So it was just kind of a no-brainer that's a gap that needs to be filled.
Sure.
And Jeff, I did have a question for you really quick. I might have missed it. I've got a spotty internet connection. How do people come to you? Do they come to you from other jails, or are they arrested and brought to your facility?
Yeah, a lot of the smaller jails that don't have 24-hour medical service or have some significant, psych issues or anything like that, they'll send us, just because we have several mental health professionals, psych NP, full-blown medical. So we're really a stabilization facility, so we can actually, take care of someone, get them to a point, even get, appointments, whatever else, and then send them back to where they can work with that client additionally. So
very cool.
So
yeah, very cool. Well, we're out of time. Thank you all three of you, Sherry, Erica, Jeffrey, just fantastic work that you're doing. I am just in awe of what you must run into and how you must deal with this on a day-to-day basis. So please take care of you so you don't burn out. We need you where you are. And I'm going to turn pass the baton back over to my colleagues, Maria and others, and Riley, about our breaking into our small groups for some more discussion. Thank you.
Yes, you will be, in a moment, you'll be sent into a breakout group. We really value this time. We want you to stay with us to share where you work, what you do. You're interfacing with correctional facilities. If you are a correctional facility, what are your challenges? And then if you are outside of the correctional facility world, how do you build those bridges? And what questions do you have? This will be really informative for our key learnings. So you will be now sent into a breakout group, and then we'll come back for a report out. So please stay with us and share who you are and your work with us in your breakout group. Some of the high points of your discussion, what you learned, and your takeaways from this morning or this afternoon, wherever you happen to be. I think it's very early in Hawaii right now. Hawaii is here. How about you, Margot? You were in my group. And Margot is with us from Illinois.
Yes, I work for a company called Health Management Associates, and we work with the Illinois Department of Human Services to support MOUD implementation in county jails throughout the state. So I was sharing that I found the information about the collaborative discharge or reentry planning between the health department and the jail to be really interesting. We are trying to think of ways in the counties we work with to bring health departments into the fold a bit more and have them collaborate with the jails in different ways. In some cases, they are the MOUD providers, but I thought this was a really exciting idea for collaboration between those entities.
Yes, you're getting a thumbs up. Other discussions from your breakout group?
I could talk from our group. Sorry, I don't know if you can see me.
Hello.
I guess one of the takeaways I took away from it from Erica actually was that I didn't know that in Washington State that this program was not funded. So it's actually really interesting, and I thought that was a pretty interesting takeaway, and maybe we should look into it more.
Absolutely.
I should just wanted to say we are funded. It's just that it's at least for the funding that we have for part of the jail, it's year to year and it's not a permanent funding. So
yeah, we were talking about opioid settlement funds in different states and the way in which they might be used to support this work in the correctional facilities, but unfortunately it may not be on the radar scope of the people who are in charge of the opioid settlement funds.
Yeah, I mean, we have 6 different grants funding it, so we're piecemealing things together. So we could use a little bit more permanent funding, but we are getting it.
And I think, I mean, all of the panelists speak to this point. These are our neighbors, our family members, our community members. This is a good investment in human beings. Rebecca, did you want to share from your group?
Sure, I've put a couple things in chat so that people can ruminate a little bit. But we had nobody that actually works in a correctional facility. So it was a group of folks who are really looking for the linkages, looking for ways to bridge the gap, looking to hear what other people are doing, working in various arenas, going to be implementing some programs, working with CDC and data. But the couple of big questions that came up are in the chat, wanting to know kind of what's the best way to engage. We had one person who's been successful engaging one jail, but one won't even return emails or anything. So, kind of where's the best place to start and go and who to talk to. And then another on referral systems and kind of if anybody's working currently with jails referring to residential treatment facilities, were 2 pieces of information additional that would be helpful, but they all acknowledge that the info was great today. So thank you to all of our panelists for all the info.
Hey, Maria, Teresa Rosales agreed to talk a little bit about what they're doing at her facility in New Mexico around peer workers. It's pretty interesting.
Hi, Teresa.
Hello. Yeah, so I was just sharing that we actually have peer support workers that are currently within the facilities. So we have 11 facilities throughout New Mexico, and in each facility there is at least one peer support, but they're actually bigger groups. We do meet on a monthly basis just to kind of, I just sit in, I'm not really part of the peer support stuff, but it's all collaborative. So if any of you are interested in ever attending one of those just to see how it works and how they've collaborated and how they've done, I'll put my email in the chat. Just shoot me an email and I'll send you the invite for next month's meeting, and you can just kind of see how they've structured their peer support program within the facilities that also gives them the connection to the out. So a lot of these people that are being released become peer support workers on the outside as well, and so they keep that connection.
Yes, and thank you so much for sharing. And Jillian just put in, someone in my group mentioned that the organization Shatterproof is doing great work. We will, you can grab that link, but we will also put it in the key learnings, and it continues a conversation that Tila, did you want to talk for a second, Tila, about stigma? And yes, the long, slow slog of addressing stigma, which I think it's great that you are participating in that. It's a never-ending conversation. And then would you want to share about that?
There were two folks in my group in particular that worked directly with populations and had some really good stuff to say. If they're willing to talk, I'd love to hear it from them.
That would be great.
Put you on the spot.
No pressure.
I can go. Yeah,
Thank
I
you,
am a peer
Monica.
support worker in Nebraska, and I do actually facilitate a couple of jail groups. I do a few rural groups in close counties to Lancaster. We are trying really hard to break down the stigmas there. They don't currently use MOUD, but we're working on that. A couple of my coworkers do the bigger jails that are in Lincoln. And then, yeah, like I said, yep, I am with WBI Wellbeing Initiative. So
Well,
I meet with oh, go ahead.
Who do you meet with?
I do Nebraska City. I do Odo County and Saunders County.
That's great. And
on a weekly basis.
Wonderful. Our door is open. As I know, Sherry, Jeff, and Erica, we're available to talk with you if we can help at all, coordinate or schedule a huddle to discuss whatever we can do to support you. Thank you so much, everyone, for this sharing. Michael, I see your hand is up. You get 30 seconds.
Erica offered to talk with a person who was interested in referrals to residential treatment programs.
Wonderful. Yes. And Erica, you want to put your email in the chat? And we are going to move on. And great. Yes. If we did not get to your question, we will circle back to you for sure. And you certainly can contact us. There is a poll on your screen. Please answer. And we are excited for April's topic, which is public health messaging and the age of fentanyl, what works. We're going to be looking at 3 public health campaigns, One Pill Can Kill, the ad councils, The Real Deal on Fentanyl, and Laced and Lethal. And we are privileged to have Laura Gover, who will be with us from the Rescue Agency, talking about public health campaigns. She is one of the developers of the Laced and Lethal campaign here in King County. So please join us in April, same time. And we will, why don't we go ahead and see the results of that poll? Looks like we had 78% participated of our great breakout group participants that are still with us. And we got a 96 on did we learn something new? 96%, that's great. 88% saying yes to plan to try something new. So thank you so much for completing that. And we rely on your feedback. If you want to get in touch with us, you certainly can. And we hope to see you in April. And a special thanks to our panelists for giving of your time and of your expertise to us today.
Thank you.
And thanks for having us.
Thank you for having us.
Bye, everybody.
Bye.
Mahalo.
Mahalo. Good morning in Hawaii.